Yes, so this PowerPoint is going to go over the respiratory system. And first thing we're going to do is go over the functions and the anatomy of the respiratory system. In order to understand its physiology, we have to understand first functions and anatomy. So the main function of the respiratory system is to the exchange of gases, gas exchange between the alveoli of the lungs and the circulatory system and blood vessels. So there is an interconnection between the respiratory system and the circulatory system. Secondary functions of the respiratory system will be regulation of pH and production of sound. But we're going to focus on the gas exchange function. When it comes to anatomy, let's go back to function again still. All right, so when it comes to the exchange of gases, there are 3 steps on the exchange of gases. Ventilation or breathing is the movement of gases from the outside atmosphere into the lungs, and then from the lungs to the outside. So inhalation and exhalation, those are the 2 movements that comprise ventilation or breathing. The exchange of gases itself, that's what we call external respiration or internal respiration. External respiration explains the exchange of gases between the alveoli of the lungs, which are the air sacs in the lungs, and the circulatory system. So capillaries full of deoxygenated blood arrive at the alveoli, and at the alveoli there is an exchange of gases through which CO2 in the capillaries is moved into the alveoli to be breathed out, and oxygen is moved, which has been brought in through inhalation, is moved into the capillary, so that the blood vessels leaving the capillary, the alveoli of the lungs, are going to be high in oxygen and lower in CO2. That's what we call oxygenated blood. That is external respiration, the movement of gases between alveoli and blood. So between lungs and alveoli and blood. So alveoli of the lungs and the blood. The blood is transported through the circulatory system to the tissues. So what arrives at the tissue is the oxygenated blood, which is again rich in oxygen, poor in CO2. At the tissue level, tissues are going to be low in oxygen, high in CO2, because tissues are metabolizing, and as they metabolize, they consume the oxygen and they build up waste in the form of CO2. So the oxygen in the blood vessel will be delivered to the tissue. The CO2 will be transported into the blood. So internal respiration is the exchange of gases between blood and tissue. And in this case, oxygen goes into the tissue, CO2 goes into the blood. And we start over again as the oxygenated blood is again transported back to the lungs. So you should be able to distinguish between external and internal respiration. So when it comes to anatomy, we're going to divide the anatomical structures of the respiratory system into 3 groups. The conducting zone structures, the respiratory zone structures, and the respiratory muscles. Conducting zone structures are the ones that bring air to the lungs. So these are the ones in charge of ventilation. The respiratory zone is where the exchange of gases between lungs and blood happens, so this is external respiration. Respiratory muscles, the diaphragm and external intercostals, are going to be the ones that are going to be contracted and relaxed in order to ventilate, inhalation and exhalation. Okay? All right, so those are the structures we're going to be looking at. So the conducting zone structures begin at the nose, at the nasal cavity. Then air is transported into the pharynx, and the pharynx is the throat, which has three parts. The nasopharynx at the back of the nasal cavity, the oropharynx at the back of the oral cavity, and laryngopharynx on top of the larynx or voice box. Air is going to travel through all three of these structures, and then it finally will arrive at the larynx, which is the voice box. From the larynx, air will be moved to the trachea, which is the windpipe. The trachea will divide at the lung level into two tubes called the bronchi, which will take the air into the lungs. The bronchi are a series of somewhat large tubes that will continue to subdivide. So we're going to go from primary bronchi to secondary bronchi, to tertiary bronchi, and it will continue to subdivide in that manner until the tubes become so small, they're about 1 millimeter in diameter, and they lack cartilage. They're only made of smooth muscle, and then we're going to call them bronchioles. And the bronchioles will take the air all the way to the respiratory zone. At the respiratory zone, that is the place where external respiration happens. That's the place of gas exchange. The structures there will be the respiratory bronchiole, alveolar duct, and alveoli. Okay, so the conducting structures. Again, we have the respiratory tree, which starts with the primary bronchi, and there's two of those. One left, one right, each going to one lung. From the primary bronchi, there will be three divisions on the right side, two divisions on the left side of secondary bronchi. And then there will be 9 subdivisions from there, actually 10 on the right side, 10 on the right and 9 on the left of tertiary bronchi. And the divisions will continue. So the lower bronchus is the secondary bronchus. Which subdivided into the tertiary or segmental bronchi. From there will be continued divisions until we get to the smallest of tubes, which are the bronchioles. Bronchioles have no cartilage. They only have a smooth muscle. They're tiny. They're about 1 millimeter in diameter or less. The last of the bronchioles is called the terminal bronchiole, and that one is half of 1 millimeter, about 0.5 millimeters in diameter. So these are tiny tubes made of a smooth muscle. The fact that they're made of a smooth muscle, that means that they can be innervated by the autonomic nervous system, and they could be made larger or smaller by sympathetic or parasympathetic innervation. So the progression of the respiratory tubes goes from large tubes with lots of cartilage, little muscle, or not much smooth muscle, all the way down to small tubes that have no cartilage, only smooth muscle. So that will be the progression. It will be a slow progression from the large to the small tubes. Progressively less cartilage, more smooth muscle, smaller tubes. The lining of these tubes also will change from a tissue called pseudostratified columnar ciliated epithelium, which we have here lots of cilia, and cilia is a protective measure against any type of debris, viruses, bacteria that are trying to gain access to our bodies via the respiratory tract. The cilia and mucus will trap these things and expel them out, all the way to the small tubes that have very little cilia, if not no cilia at all. So again, that will be the progression. Okay, so you should know how the tissue changes and what that means as we go deeper and deeper into the respiratory conducting zones. The last of the respiratory conducting zone tube is the respiratory that's the first one, is the terminal bronchiole. This is wrong. The last of the bronchioles of the conducting zone is the terminal bronchiole. I'll fix it in the PowerPoint before I upload the PowerPoint. That should be terminal bronchiole. That's the last of the tubes in the conducting zone. All right, so respiratory system anatomy, again, air goes into the nasal cavity. There it will be humidified, filtered, and cleaned and warmed, goes into the nasopharynx, oropharynx down here, keeps traveling through the pharynx. Laryngopharynx, then it goes into the larynx, the trachea, and then the trachea is going to divide into two primary bronchi, one going to the right, one going to the left. From bronchi, again, larynx, trachea, bronchi, notice that the right side, the lungs, have 3 lobes, 1, 2, and 3. On the left side, there's only 2 lobes, 1 and 2. So the secondary bronchi is going to divide, is also called the lobar bronchi because it subdivides from primary into secondary according to the number of lobes. So on the right side, we're going to have 3 subdivisions. So it would be, it's hard to see, because it will be 1, 2, and 3, 1 for each lobe. On the left side, there will be 2 subdivisions. That's a little bit easier to see right there. 2 subdivisions on the left side for the secondary bronchi. Secondary bronchi subdivide into tertiary bronchi, which are called segmental because they're going to subdivide into and go into the segments of each lobe, being 10 segments on the right, 9 segments on the left. So we're going to have 10 tertiary bronchi on the right, 9 tertiary bronchi on the left. But this is just to show the subdivisions. And from there it continues on into progressively smaller and smaller tubes, which are going to have less cartilage, more smooth muscle, less cilia. There has the progression with the last tube being called the terminal bronchiole. So we have the primary bronchi, this is going to be on the left side. So primary bronchi, secondary bronchi, 2 secondary bronchi, tertiary bronchi, you're going to have to count into, I guess 3, 4, there should be 9 of those. And then progressively smaller until we get to the terminal bronchiole, which is the last of the conducting zone branch. From there, the air is moved into the respiratory zone. So that little square right here is the respiratory zone. And the respiratory zone will be the location for external respiration. All right, the respiratory zone will have respiratory bronchioles, alveolar ducts, and alveolar sacs, which are clusters of alveoli. So individual alveoli are clustered into these little alveolar sacs. So that's the progression of the path of air. Alveoli are the air sacs. There are millions of them, 300 million alveoli. And so pretty much the entirety of the lungs volume will be these 300 million alveoli or air sacs. So lungs are actually very, very light because they're mostly just little air sacs. So here's the terminal bronchiole. From there, it divides into respiratory bronchioles, which divide into alveolar ducts, which we cannot really see in this picture. And from there into from the alveolar duct come out these little alveoli. All right. So this is the site of external respiration, the respiratory zone. Gas is going to move by diffusion. Diffusion requires three things. Diffusion requires large surface area, which we have if we have 300 million alveoli. It requires a thin membrane. And it requires a concentration gradient for the movement of gases that are going to diffuse. Okay, so we have the large surface area. We have 300 million alveoli. We have a thin membrane because the tissue of all of the respiratory zone structures, starting with the respiratory bronchiole, is going to be the thinnest of tissues, simple squamous epithelium. So all of these structures you see in this picture are going to be flat little cells, one layer of flat little cells. That's what the respiratory zone is made of. There's your thin structure, your thin membrane. And then there will be a difference in concentration between the gases that are going to be exchanged. Because if you remember what we talked about with external respiration was that we had the oxygenated blood with a low concentration of oxygen in the blood, but a high concentration of oxygen in the alveoli. So high to low, oxygen will diffuse from alveoli to capillary. By the same token, there was a high concentration of CO2 in the capillary, low concentration of CO2 in the alveoli. By simple diffusion, CO2 will travel from high to low concentration, going through that concentration gradient, and the movement was allowed because of the thin membrane. You compromise any of these parameters for diffusion, and you cannot have diffusion. So if you have too many sick alveoli that are non-functioning, now you're compromising the large surface area. If the membrane thickens, now you're compromising diffusion by not having a thin membrane. If the concentration gradients change and they're not what they should be, now again you're compromising the movement of gases. All right, so I cannot emphasize enough how important it is to have these three parameters to have external respiration going on. Again, another picture of the alveoli. In here, what you can see is the relationship between the alveoli capillaries, and each little alveoli has its own little set of capillaries that they deal with. Also notice here how the alveoli also have elastic fibers. So they're made of simple squamous epithelium, underneath a little bit of connective tissue with elastic fibers that are going to make the alveoli little bitty thin sacs that can expand and then recoil, okay, as we ventilate the alveoli. There is no smooth muscle, there's just the elastic fibers. This is showing you the cells that make up the alveoli. There are three populations of cells making up the alveoli. We have the type 1 cells, which are the simple squamous epithelial cells that make most of the alveoli. Type 2 cells are special cells that make a soap like chemical material called surfactant. And we'll see what surfactant is important. And then remember that the tissue is simple squamous epithelium. There is no cilia, which was a protective structure. So we need other means of protection. So now we have the second line of defense, which are the cells, immune system cells, macrophages, going around, hopefully eating up things that shouldn't be there. So these tan color cells are the type 1 cells. The green cells are the surfactant secreting cells, and the blue cells are the macrophages. And then you can see the relationship between alveolar capillaries and alveoli. Also notice that the alveoli are connected with each other through these little pores. So air can rush in from one alveoli to the other. This is a depiction right here of the respiratory membrane, the thin membrane through which gases can exchange between alveoli and blood vessel. So respiratory membrane is made by the simple squamous epithelium of type 1 cells in the alveoli, and against that is the simple squamous epithelium that makes up the capillary vessel. So we have two simple squamous cells next to each other. You cannot get any thinner of a membrane than that. So you can see oxygen diffusing from alveoli to blood, CO2 diffusing from blood to alveoli. All right, and that's external respiration. Okay, now physiology of respiration, and now I wish I would have said ventilation or respiration, but okay. Again, I'll fix it because I don't like it the way it is. So it will be physiology of ventilation. All right, so ventilation being inhalation and exhalation. So how do we bring air into the lungs? How do we expel the air out of the lungs? So this is accomplished because we're moving gases. And the good thing about gases is that when you increase the volume of the container where the gas is housed, that's going to lead to a decrease in the pressure that the gas exerts on the container. And if the pressure on the outside, the atmospheric pressure, remains constant, so this will be atmospheric pressure, which does remain constant. If the pressure inside the lungs falls, then the pressure in the atmosphere will be higher, will remain higher than the pressure inside the lungs. And gases will move from a zone of high pressure to a zone of low pressure. So we're going to inhale, bring air in. So what's going to happen during inspiration is that we're going to contract respiratory muscles. There are two respiratory muscles, the diaphragm and the external intercostals. And what these muscles do is they are going to expand the rib cage. The external intercostals are going to push the rib cage front and sideways. The diaphragm is going to pull it downward. So between the actions of these two muscles, the rib cage is expanded. Now, one thing that I didn't mention was that, remember from earlier in the semester, we talked about serous membranes covering organs like the lungs. The serous membrane covering the lungs was the pleura. And we had the visceral pleura touching the lungs. And then there was a second set of pleura called the parietal pleura, which was on the outside. And the parietal pleura is actually attached to the walls of the thoracic cavity. In between these two membranes, which is actually, we consider the one membrane, but in between there's a little bit of a space with fluid, water essentially, called the pleural cavity with pleural fluid. So because you have two thin membranes and water in the middle, the two membranes cling to each other because water clings. Water is a charged molecule that attracts other water molecules, and so water is like a glue. So you have parietal and visceral pleura glued to each other. Okay, so if you expand the thoracic cavity and the parietal pleura is essentially attached to the thoracic cavity, when you begin to expand it, you pull on the parietal pleura. But because the parietal pleura is glued to the visceral pleura, when you expand the thoracic cavity, you're going to essentially pull on the visceral pleura and pull on the lungs. So the volume of the lungs is going to increase. It's going to stretch as we expand the thoracic cavity. We're going to increase the volume. If we have a bigger volume, the chances of the air molecules bumping against each other or bumping against the walls of the vessel decreases, which makes the pressure decrease, and air will be rushed in from the atmospheric pressure, which remained higher than the inside at this point. It's going to go inside, and we're going to inhale. The opposite mechanics happens during expiration. During expiration, what we have now is relaxation of the respiratory muscles. When we relax the respiratory muscles, which will be the external intercostals and the diaphragm. When we relax these muscles, now the volume of the thoracic cavity decreases. If we decrease the volume, we're going to increase the pressure. The pressure will be higher than atmospheric pressure. And so air is going to rush out from lungs to outside. And that's the expiration process. The difference in pressure between lungs and atmosphere does not have to be very big. We're talking about a difference between 1 millimeter of mercury. That's all it is. So if the atmospheric pressure is a constant of 760 millimeters of mercury, all the lungs have to do is increase it by 1 millimeter of mercury, 761. And that's enough difference for the air to rush out. So the difference is actually very, very small, but is enough for the system to work. So you should know the principle behind expiration and inspiration. Now, this is showing you the relationship between lungs and pleura. And let's see, parietal pleura, I guess it would be out here. Visceral pleura will be over here. They're giving you an exaggerated pleural cavity. It's not this big, obviously. But the reason why they're doing this is because they're showing you something important. The intrapleural pressure is always negative. It should always be negative. Negative meaning less than atmospheric pressure. So if atmospheric pressure is 760 millimeters of mercury, the pressure in the pleural space is always a negative pressure, always less. Intrapleural hovers between 756 millimeters of mercury all the way to 750 millimeters of mercury. So it's -4 to -6 millimeters of mercury less than atmospheric pressure. What that does, and actually that will be more like 758, not 50. All right, so essentially what that does, having a negative pressure in the pleural space creates a vacuum, and the pleural space is always pulling on the lungs and preventing their collapse. The lungs tend to collapse. That is because air that arrives at the lungs is 100% humidified. This is lots of water in the alveoli. So what we have is these flimsy little sacs filled with air, but the air is 100% humidified. So there's tons of water molecules. And the water molecules cling to each other and create forces that are making the alveoli collapse. What's preventing alveolar collapse? is going to be several forces that are going in the opposite direction. One of them is going to be surfactant. Surfactant is a soap-like substance that is going to position in between water molecules. So surfactant will surround water molecules and prevent them from clinging to each other. And that's going to try to prevent alveolar collapse. So that's one of the forces which will prevent alveola from collapsing. So surfactant is needed to prevent water molecules from clinging and collapsing the alveoli. Another force helping preventing the collapse of the lungs is the negative pressure in the intrapleural space, which creates a vacuum that is constantly pulling on the lungs and preventing their collapse. Remember that the alveoli had elastic tissue. Elastic tissue is a rubber band. The minute you extend the rubber band and you let it go, the rubber band goes back to their original shape. So the lungs always have forces wanting it to collapse. What's preventing the collapse? One of the things will be surfactant. The elasticity of the lungs is another one. The intrapleural pressure is another one. Okay, so it's important to keep that intrapleural pressure as negative pressure. Okay. So this is showing you the differences in volume and pressure with inhalation and exhalation, and showing you what the intrapleural pressure is doing. So during inspiration, breathing in, the volume of the lungs is increasing, the pressure is decreasing. There is an inverse relationship between volume and pressure. And notice that as we expand the cavity, the thoracic cavity, we're pulling on the lungs, we're pulling on the pleural cavity also, and the intrapleural pressure decreases even more. It goes from -4 all the way to -6. So it's really pulling on those lungs at that point. Then we're going to begin to breathe out. We're going to decrease the volume of the lungs. We're going to decrease the volume of the pleura, bringing the pressure back up to -4, is still negative. And we're going to decrease the pressure in the lungs. Air will rush out. So you should be familiar with mechanics of ventilation. Homeostatic imbalance would be a lung collapse. Atelectasis is a lung collapse. What can cause a lung collapse? Well, let's mess with the intrapleural pressure. Anything that allows air to go into the pleural cavity. For example, a stab wound, a puncture wound will create pneumothorax, air into the pleural cavity, which compromises the negative pressure. It becomes positive. There is nothing pulling on the lungs now. The lungs collapse. It could also be a broken rib that maybe punctures the lungs, or the pleural cavity of the lungs. Another thing could be simply an infection. Plugged bronchioles will do it. Okay. Another thing could be inflammation, accumulation of fluid. That will do it. Okay. That may also compromise the pleural cavity and lead to atelectasis, lung collapse. All right, so there's always forces that are leading us to a collapsed lung. The two forces is the elasticity, the recoil of the elastic tissue in the lungs, in the alveoli. That's one force that is making the alveoli smaller, collapsing the lungs. The other one is the water in the alveoli, the moisture in the alveoli. That's called the surface tension of the water molecules clinging to each other. How do we prevent these forces from collapsing the lungs? The outward forces, the elasticity of the wall itself. Okay, as long as the elastic tissue remains healthy, a rubber band can be stretched and then recoiled, and then is stretched and then recoiled. So as long as that happens, the recoil is okay because we're going to stretch it again. Okay, so the expansion of the thoracic cavity is a stretch in the lungs. That's one thing. The other thing is the negative intrapleural pressure, right there, which again prevents lung collapse because it's going to pull on the lungs, the negative pressure. And then obviously surfactant will lower the surface tension due to the moisture in the alveoli. So things that influence pulmonary ventilation, things that are making, again, the lungs collapse, or that could potentially make the lungs collapse. Airway resistance, plugged conducting zone tubes, like bronchitis or asthma. So we increase airway resistance, we're going to decrease the volume of the lungs. Less air can arrive at the lungs. Volume of air, I should say, volume of air in lungs. There we go. All right. Alveolar surface tension, again, that is the water, moisture in the alveoli. We can fix that with surfactant. Lung compliance. This means the elasticity of the lungs. We mess with any of these factors and we compromise ventilation. So if there isn't enough surfactant, that compromises ventilation. If the lung cannot recoil or expand, that compromises ventilation. If there are plugged tubes, that compromises ventilation. So mess with any of those three factors, you compromise ventilation. So airway resistance. Our breathing becomes strenuous. We have dyspnea, meaning labor breathing. An asthma attack will compromise airway resistance. What do we do to try to fight against an asthma attack? We're going to dilate the bronchioles. So the tubes that have a smooth muscle are the bronchioles. So they are the ones that can be innervated by the autonomic nervous system. And the sympathetic nervous system is going to dilate the bronchioles. It's going to relax the muscle. Relax the muscle and cause dilation of the airways. On the other hand, parasympathetic nervous system is going to have the opposite effect. Parasympathetic is going to constrict the muscle and constrict the airways. So if we want to relax the airways and dilate the airways, we use sympathetic drugs like epinephrine, which is the hormone of the sympathetic nervous system. So that's a sympathetic nervous system drug. So we either use the sympathetic nervous system drug or we block the parasympathetic nervous system. We use a drug that blocks parasympathetic receptors. Either approach or both approaches are used during an asthma attack. All right, so again, we're going over the factors that compromise ventilation. We mentioned airway resistance. Factor number 2, alveolar surface tension. We can counteract that with surfactant secreted by type 2 cells. Surfactant is a soap-like substance that introduces itself in between water molecules and prevent alveolar collapse. We don't have a problem with surfactant. We have it, we're healthy, etc. Who has a problem with surfactant? Premature infants. In premature infants, the lungs are not mature enough to create surfactant, so they suffer sometimes from infant respiratory distress syndrome, meaning the alveoli are collapsing. That's why in premature infants oftentimes have to be put in respirators. If you can prevent the delivery, the early delivery, by just a few hours, they can give the mother cortisol. Cortisol accelerates lung maturity. So if you can buy a few hours, 24 hours may make all the difference between an infant that has to be put in a respirator and one that doesn't have to be put in a respirator, because the cells may be mature enough to make surfactant. Maybe in elderly patients we begin to see surfactant compromise, but typically it's not an issue in most healthy people. Now, lung compliance is a different story. Lung compliance is the ability of the lungs to dilate, to stretch, and then recoil. And that is thanks to elastic tissue. As long as the elastic tissue is healthy, we're okay. As long as the thoracic cavity is healthy, we should be okay. So, distensibility of lung tissue. That's important for lung compliance, the ability of the lungs to be a balloon. A balloon is something that stretches with very little pressure. That's how the lungs should behave. Diseases like fibrosis of the lungs or emphysema may compromise compliance. Emphysema, okay, because they're going to compromise with the connective tissue of the lungs. All right, what else? Oh yeah, other things that compromise compliance would be broken ribs. All right, so compliance diminished by scar tissue, that's fibrosis. Reduced production of surfactant, okay, that's typically maybe in old age or premature infants. Decreased flexibility of the thoracic cage. This is normal in old age. As we age, the thoracic cavity has more bone, less cartilage, decreased flexibility. Other things that could cause less flexibility, deformities of the thorax. Severe scoliosis, for example, will do it. So now the thoracic cavity cannot expand. Ossification of the costal cartilage, in the ribs. That's old age. We're all going to experience that one if we live long enough. Paralysis of intercostal muscles. That could be maybe a paraplegic may have this problem. So that will compromise the ability of the thoracic cage to expand, compromises ventilation. Okay. All right. Last thing we're going to talk about are respiratory volumes, the volumes of air being moved in and out of the lungs. A device that measures this air is called an spirometer. And an spirometer is going to give us an idea of the air that is moving through the lungs. So the volumes of air that can be moved through the lungs during what we call quiet breathing, which is what we do normally. The muscles that are being used are the external intercostals and the diaphragm. And quiet breathing is the tidal volume, TV, which is about 500 mils of air. So this little curve right here, this little curve, and these little curves are the tidal volume, quiet breathing. If you want to inhale more air, now you need to call more muscles into play. Things like the pectoralis minor, the scalenes, the sternocleidomastoids, to breathe in more air. That creates the inspiratory reserve volume. Okay. If you want to expel more air out, now you again have to pull in more muscles, in this case the abdominal muscles and the internal intercostal muscles will allow you to expel more air. That will give the external reserve, the expiratory reserve volume, or ERV. You do have to know these volumes. The volume of air trapped in the lungs that cannot be moved in or out unless the lungs collapse is the residual volume. So those are the volumes. The capacities are the added up volumes. So TLC, total lung capacity, are all of these volumes added up. So TLC is going to be the tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume. A more important value is the vital capacity, because that one will measure, that's important in the sense that we can measure it better, will be the vital capacity, because that one is measuring the volumes that can effectively be moved in and out of the lungs, utilizing as many muscles as possible. So that will be the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. No residual volume, because that one cannot be moved unless we collapse the lung. Inspiratory capacity is the maximum volume of air we can breathe in, utilizing all the available muscles of inspiration. So that will be tidal volume plus inspiratory reserve volume. if we breathe that air in and then we expel it out, utilizing the extra set of muscles. Then the functional residual capacity will be the air that could be expelled utilizing the forced expiratory muscles plus the air left inside the lungs. Okay, so do know the volumes, I do know the capacities. So a pulmonary function test is the body of tests that are designed to measure the function of the respiratory system. So a respirometer will measure pulmonary volumes. And pulmonary function tests will put the patient into 3 categories. The patient is either normal, the patient may have an obstructive condition, disease, or a restricted disease, lung diseases. The kinds of volumes that are most useful measure is the forced vital capacity, which is the volume of air that is expelled with force, utilizing all the possible exhalation muscles after taking a deep breath in. So we do the inspiratory capacity, and then we expel as much as possible, forced expiration, and everything you can expel within 6 seconds. And this is typically reduced in restricted diseases when the lungs are smaller. Forced expiratory volume is similar, but in this case, we're measuring the volume expelled during the first second of forced expiration, because in theory, during the first second, we should be able to measure 75% of the expelled air. So most of the expelled air, unless we have obstructive conditions that doesn't allow us to expel as much air in that first second. So a patient with an obstructive disease, we have a decreased airflow. So this is a condition of the conducting zone. So that the TLC, the lungs themselves may be able to hold as much volume as before. It's the movement of the air in and out through the conducting zone that is being compromised. There will be a low FEV1, so the first second you will not going to be able to expel as much air as normal, because again, there's something wrong with the tubes. So that will give you a low FEV1 FVC ratio. There is an increased airway resistance. The total lung capacity is typically increased or normal. Okay, nothing wrong with it. So it may be increased if there is a problem with elasticity. And then we have a decreased respiratory flow rate because we have an obstruction. Examples: asthma, COPD will do it. Chronic bronchitis, emphysema, cystic fibrosis, bronchiectasis are conditions of obstructive lung disease. Restrictive lung disease gives you a problem with the lungs themselves. So in this case, there's a reduction in TLC. FEV1 and FVC may be normal because you don't have a problem with the expelling the air with the conduits, or it may even be elevated. Now there's a structural problem with the lungs themselves. So there could be fibrosis of the lungs, for example, an infection in the lungs, for example. Okay, so now we have a decreased TLC. There might be a decreased lung recoil. That's what's giving you the elevated FEV1, because you're accumulating air. You cannot expel as well. You cannot expel all the air every time. Pleural diseases, okay, so pleural diseases, alveolar diseases, interstitial diseases, thoracic cage diseases will give you, or infections like pneumonia, will give you restrictive conditions. Okay, last thing we're going to talk about, a couple of PowerPoints, actually one PowerPoint on respiratory pathology, ARDS, because that is acute respiratory distress syndrome. This is what we're dealing with right now with COVID-19. This is something that a lot of these respiratory viruses are going to cause. Influenza, SARS cause the same condition, except that COVID-19 seems to give you a more dramatic ARDS. Very quick, very dramatic. ARDS is essentially a tremendous inflammation of the alveoli. If you have inflammation, you're going to have thickening and fluid buildup in the respiratory membrane, which, remember, has to be thin. The minute that respiratory membrane becomes thick, now you compromise external respiration, and that's exactly what is happening. The patients are asphyxiating to death because the thickness of the membrane doesn't allow for the exchange of gases. So that's why they have to be put in a respirator. The problem is the tremendous acute inflammation, fluid buildup, tremendous inflammatory response that is not only causing a fluid buildup, but is also causing clots in the capillaries of the lungs, which now you're having cardiovascular problems thrown into the whole picture. Ventilators are going to open up the alveoli and force air in. However, too much air in and out is going to compromise the alveoli, because the alveoli is a very flimsy little sac. It's going to put a stress in the alveoli. So what they do is they reduce the tidal volume that's going in so as to not stress the alveoli. If you reduce the tidal volume, now the patient feels like they're asphyxiating, and they try to fight the respirator. So now you paralyze the patient. And now something else they do nowadays is they flip the patient upside down, face down, and that seems to also improve ventilation. So they're using low TV and a prone position on the patient to prevent alveolar collapse. The problem with a low TV is that now you're retaining CO2. So now you're going to have problems with pH also. So the solution is you're buying time, trying to get the patient to get better on its own and fight the infection before the inflammation does them in. Okay. The risk factors: obesity, cardiovascular disease, diabetes. All right. So that is the end of this recording.